feel good. George Fox is here, and as he told me, he's the top man that goes around all over New York, George? All over New York to talk about these programs. Okay, everybody seated? Because when we move the chairs around, it's hard to hear everybody. We are sending, for my own use, I know all of you have to be 60 and over and 65 to get the Medicare. We have the white sheet going around. Please sign the white sheet because everybody who walks in this center is counted by Nassau County, and we need the numbers, so you're counted in. Hopefully he's going to do the lecture. The lecture's going to be about 50 minutes. If you hold your questions until about 10 to 12, he'll answer your question. Okay, guys, please listen just for a minute so he can get started. If you have Tony, why don't you come and see this way? Tony, move your chair up here, you can see. Okay. If you have a specific question, a personal question, he will stay after the lecture and you can go in the nurse's office and he'll answer your question in private there, okay? So try to keep your questions until the end, which makes it better, all right? He'll give you 10 minutes after he speaks, and then if you have something private, if there's 10 of you, you just have to wait your turn, okay? Because I have all afternoon. The center's open until 8:30 tonight. I don't know if George has got that much time.
Sure, why not?
Okay, now I'm going to hand the mic over to George, and he's going to start his presentation. Okay, thank you.
Thank you so much. Hello, everybody. How are you? Like she said, I'm George Fox. I'm from Medicare Help Center. We're an informational advocacy group. We've worked with Medicare beneficiaries for the last 25 years. What I'm going to do today is I'm going to go through not working? Wow. I feel like Dick Clark, you know. First I want to check, does everybody have one of these flyers in front of you? Okay, this is very important. You're going to be able to follow around in the whole seminar. I'm going to touch on a lot of the material in this book, and it's a reference manual you can use after the event. On the back page, this microphone could be like a wireless, you know what I'm saying? On the back page of your form, the last page, there is actually a questionnaire page where you can write down questions that can come up. Because I'm going to try to plow through this event in less than 45 minutes for you. If you can write your questions down, and then like is illustrated before, we're going to answer all your questions after the event, but I know a lot of you want to get out of here at noontime. Okay, so let me get going here. This is a Medicare 101. Yes, sir?
I need it. Thank you. Thank you very much.
They're free. I got lots of them. Okay. This is considered a Medicare 101 type of event, which means I'm going to talk in very broad, general terms, and try to stay away from specifics. And again, you're going to develop a lot of questions as we go along. I touch on a lot of subject matter. So again, write your questions down. I'll be able to get through this thing as quickly as possible. Okay. Again, we're going to try to keep this to an hour. Okay. Let's see. This is the most important aspect of this whole seminar. Everybody's situation is very unique. Even though Medicare as a federal program covers everybody in the system, your specific situation will be unique based on how you address your risk tolerances and so forth. So again, because this is a general event, just keep in mind that your situation will be unique. There's a couple things we need to know about. CMS prohibits me from requiring you to provide contact information. However, I can't contact you unless you give it to us. There's no outbound phone calling in this environment. You have to call us or tell us to call you, one of the two. That's a very important thing to know about. I don't want you to think we forgot or ignored you in any way. I'm also going to limit my discussion to plans and related information to Nassau and Suffolk counties. Medicare is a federal program, as we all know, but it's very specific by county, so I'm going to limit the discussion to Suffolk and Nassau counties only. There's a lot of rules I got to follow too. I'm going to point out a few of them really quickly. This is considered a formal event. Why is it a formal event versus educational? Because I can't discuss specific plans in an educational event. So because I make it a formal event, if you have a specific plan question, I can answer that for you. Just write it down. Okay? Let's see. I can't answer any questions related to your health. So if you have a health issue, I can't answer that in this environment, but if you write it down, I'll address it privately. The most important one is number 11 in your booklet. I'm going to use standardized language, such as zero plan premium. What does that mean? It means you don't pay anything for it. It's free. But I can't say it's free. I have to say it's a zero plan premium. So as I use certain language, you say, that's kind of stupid the way you said that. It's not me. It's the standardized language that's required by federal law. Okay? Let's see. This little background that's in your book, it's got my educational background so you know who you're dealing with. I'm considered a CFP. I have a degree in business. I hold licenses in all 50 states. I'm certified financial planner. So I have a lot of background. It's all in your information here. But the most important thing for you to know about is that I have over 25 years of experience underwriting Medicare programs throughout the country. I work for a big carrier. Probably you all know it, Wild Kingdom. I can't say the name. All right. I started with them over 25 years ago. So I've been in the Medicare business over 2.5 decades. But I have a lot of experience in a vast array of insurance underwriting issues. Okay, I'm going to limit the discussion to these four subject matters here. First, I'm going to review some important changes that I picked out that are going to impact you in 2014. There are a lot of things happening. I only picked out 3 that I thought were really significant, but most importantly, transmit or telegraph to you changes that are coming. Because when you think about how the federal programs work, there's always a prelude or something occurs and then it happens. So these are things I saw that I kind of identified as helping you to see what's going to happen in the future as things go along. Second, we're going to discuss how you enter the Medicare system if anybody is under 65, which you all look to be, right?
Yeah, sure. Thank you.
Then we're going to discuss risk solutions, which is really what this is all about. How do you eliminate the risk associated with Medicare? And again, I'll address any questions in the 4th segment. So let's get right into it. The first thing I identified as I was looking at all the things that are occurring in 2013 is physician fee schedules are set to change. Well, there's no surprise there. Every year physicians are complaining, hey, I'm getting less and less. But if you read through this entire act here, which is 1848 of the act, basically what it's saying is that there's something called the sustainable growth rate in Medicare. It's how they forecast the continuous growth of the cost of Medicare benefits. And if the sustainable growth rate goes up more than it's supposed to in any particular year, they just adjust the payments for physicians down to compensate for it. So this, if you read this whole article, which I'm not going to get into right now, essentially what's going to happen is your physician, the guy who's practicing and delivering medicine to you, his reimbursement is scheduled in 2014 to go down by about 15%. So how does that affect you? Well, it affects you in a couple different ways, but most importantly, your doctor's going to be making less money. And doctors are in business. They're in business to stay in business. And the way they're going to sustain themselves in that industry is to transfer the care or how they deliver health care to you to lower paid medical technicians. And that's why you see a lot of physician assistants, nurse practitioners, phlebotomists, and so forth becoming more and more prevalent in physicians' offices, because what they're trying to do is overcome the reduction in the compensation rates they get from Medicare, which are low according to them to start with. So this is an important thing that's telegraphing to you that your physician is going to have to make an economic decision as time goes on and how he's going to deliver health care to you with less and less revenue, right? Now this was all, of course, in conjunction with something to do with Medicaid. If you all know, you're a Medicare and there's Medicaid. There's 2 separate systems in the United States. Medicare is an entitlement. You're entitled to it by law. You paid for it. Medicaid is not an entitlement. It's a welfare program. People become eligible for it based on what's called means testing or income testing. So what's happening here in this whole thing is that the Medicare rate is going down for physicians. And because the Medicaid rate was very low to begin with, they're trying to bring the Medicaid rate up so that now your physician can possibly treat Medicare, Medicaid, and really almost get the same thing, because in 2013 they passed another law that says if your doctor got paid $100 to treat you as a Medicare patient, but only $10 to treat you as a Medicaid patient, the federal government would step in and pay the $90 difference. So what does that mean? They've essentially brought 2 federal systems, Medicare, Medicaid, par with each other, so now it doesn't matter whether your physician is treating you as a Medicare or a Medicaid patient, he's getting paid the same. Why is that important to you? because there's more patients in your physician's practice, and as a result, again, he has to manage his practice to deliver more health care to more people at a lower rate. You see how that's all going? Right. So this is all an attempt to balance budgets and so forth at the federal level. Here's another indication that I thought I saw was very interesting. This is not a new phenomenon, by the way. If you read through here, this is a group called Carillon Clinic Medicare Health Plan. They're based in Virginia. This is just one of many Medicare Advantage plans throughout the country that come into the industry over a couple of years and find that they cannot maintain the delivery of health care benefits at the same rate they initially offered it to you because they're losing money. So what do? They cut benefits, they raise premiums. Some of you have seen this in your current plan. If you're in current plans, you're getting notices, hey, my premium's going up, I'm cutting benefits here. That's because those are managed health care plans. They try to deliver benefits at less cost, and they can't do it. So here's a good example of one plan in 4 years, entered the market, acquired 3,200 Medicare beneficiaries, and now they're sending out letters to everybody saying, oops, sorry, couldn't do it. You're all canceled. Go back to original Medicare and find another plan. Doesn't seem so bad, but if you've established yourself with a medical management practice, and now you've got to make all these changes again as you get older, it becomes more and more difficult. So it's very, very important. This is just a good way to indicate to you, it's very important that you know who you're dealing with and whether or not they're actually going to stay in the business. A lot of companies, just like any other business, enter the industry with an exit plan from the start. All right, so you have to kind of know who you're dealing with and look at the sustainability of the carrier you're dealing with when you choose a healthcare plan. This is actually a good thing. This came under the Affordable Care Act as part of the overall revamping of Medicare. But all these types of preventative services and everything were now covered at 100% under your Medicare benefits. You probably all saw this last year in 2013. They added, I thought it was interesting, obesity screening, counseling, pap tests, pelvic exams, prostate cancer screening. These are all preventative services that prior to the enactment of the law were not covered because they were not considered medically necessary. But now they consider preventative care covered as a benefit under Medicare. So it's very important. The one thing I thought was interesting, STDs are covered. Go figure, I don't know why. Yearly wellness visits and so forth. So all these benefits came in as part of the revamping of Medicare, which are a good thing for you. So let's kind of get into the Medicare system and see how it works. Any questions? Like I said, write them down in the book. There's lots of other changes you should look for, or you can call our offices. Things are happening all the time. I just don't want to waste a lot of time going through all 12,000 of them. Okay, so this is Albert Einstein, one of my favorite guys. And you know, he didn't know much about history or biology or health insurance, so of course he came to people like us to help him out. Oh, sorry, you go over here. That was a bit of a joke. Here's some Medicare basics. For those entering the system at age 65 due to disability, you could be at any age under 65 and qualify for Medicare. But here's a little trivia that I want you to kind of think about. Everybody know who's in the middle picture there signing that document? That was Lyndon B. Johnson. He signed the Medicare Act in 1965. But do you know who actually brought the Medicare law to Congress to get through and get passed? Anybody? It's the guy sitting right next to his right. Harry Truman, that's right. Harry Truman actually brought the law into effect. It was Lyndon B. Johnson who signed it. Who else was the first Medicare beneficiary in the United States? Anybody know? Harry Truman. Harry Truman. The second was his wife, Bess. So I think that was an interesting aspect of the system. There are 4 parts to Medicare now, but in 1965 there were 2 parts. Part A, which is the hospitalization program. That is a government-run program. This is important to know. Part B is the doctor. That is a government-run program. Now you have Part C, which actually came into law in 1997, which is a commercial insurance company-run program with government oversight. This is, watch the trend here. Government-run, now commercially run with government oversight. And then in 2003, they brought in what? Part D, because you wanted drug coverage. That is commercially run monopolies with government oversight, basically meaning there is no government-run Part D program. It's all commercial insurance providing Part D benefits. So you see how the trend is away from government-run programs to commercially run with government intervention. Okay, Part A is free. You get it as long as you work 40 quarters, which you all probably know, right? It's a free program. They call it premium free Part A, but it's not actually free because you pay for it over your working life, right? What does it cover? Semi-private room and board, operating rooms, anything from the ER room in is covered under Part A. Meals, nursing, medications while inpatient but not outpatient. Part A coverage begins on the first day you turn 65, the first day of the month in which you turn 65. And I'm going to skip a lot of this. Here's the important thing. In 2013, the premium for Part A is 0, premium free, right? Unless you didn't qualify because you worked 40 quarters and so forth. You probably don't know this. I'm going to skip a lot of this. Okay, but here's the most important thing about Part A. Part A has a deductible when you enter the hospital. The minute the doctor says, hey, you're admitted, you imply a deductible in 2013 of $1,184. It's going to go up in 2014, and it always goes up. But here's the thing. If you're in the hospital more than 60 days, which could occur, you have to start to pay $296 per day along with Medicare. And if you stay past 90 days, you have to pay $592 per day in your lifetime reserve. So if you have Part A only coverage, that's all you have, you're exposed to a total risk of about $45,000 in hospitalization. So if you had a protracted hospital stay, you could run up $45,000 of cost to you. That's why everybody gets secondary insurance of some type to eliminate that risk. So Part B is the second part of Medicare. That's the second part that was enacted in '65. Part B is your doctor. It is not premium free. You have to voluntarily enroll in it. And it costs you about $104.90 per month in 2013. Virtually everybody should buy Part B. There's really no reason to unless you're still working and have a plan through an employer. So if you're working, you might want to opt out or waive. But if you're not working, you get in at age 65, buy it, and go from there. Let's see, I'm going to skip this here. What does it cover? Physician, ambulance, durable medical equipment, diagnostic x-rays, speech therapy, preventative services, which came in. The most important thing about Part B to know about is everything from the ER door out. It's when you see your doctor. But here's what is important here. In Part B, it's good coverage, but you have a calendar year deductible. It's nothing. It's $147. But you see that second part right there? It says coinsurance. Your coinsurance is unlimited. So like if you had a $100,000 Part B claim and you had no secondary cover, you could be exposed to 20% or $20,000. And again, that's why most people get secondary coverage with original Medicare, because the 20% goes on forever. It's unlimited risk. So when you're looking at your Part B coverage, your doctor, hospital A/B coverage, it's good coverage, but it's not complete coverage. And that's why we all get some kind of secondary insurance, or since 1997, you could potentially enroll in what's called the Medicare Advantage plan. So, if somebody's I'm going to skip through this real quickly, but if you're going to be turning 65 from this month forward, you will enter the Medicare system on the first day of the month in which you turn 65. And this is the cycle how it goes. This is in your booklet. Let me just skip through this here real quickly because I know we're under time constraint. But you essentially had 90 days before, the month of, and 90 days after your 65th birthday to enroll in Part B without penalty. So in other words, if you were born in June 2nd of 1948, you could have enrolled all the way back to March, April, May, plus June, and then July, August, September without getting a penalty or being deferred. If you don't enroll during the initial enrollment period, you will have to wait to the general enrollment period, which starts in January of every year. So it's very important if you're turning 65 that you enroll during your initial enrollment period 90 days before the month of your birth. Everybody got that? Whoever's turning 65 in the room? Okay. Otherwise, you got to wait till January. You'll enroll in January. Your coverage will begin in July. Where are you there, buddy? Come here. You have to answer the phone by law. Nobody gets a voicemail. Okay, so It's very important you don't miss your open enrollment during your initial period. Otherwise, you could possibly have a break in coverage, and that could subject you to a penalty. Let's skip this here. I just want to get to the good stuff, like everybody else. Right? Okay, now we're going to talk about Part C plans. This is something that came out in 1997. What's the difference between Original Medicare and Part C? Original Medicare is the government-run program that provides A and B, and traditionally since 1965, most people purchased a Medicare supplement to wrap around that coverage as secondary cover and covers all the deductibles and coinsurance we just discussed in Medicare. That was tradition, but in 1997, under the Balanced Budget Act, Bill Clinton signed that law and brought Medicare Advantage into the mix. What is a Medicare Advantage plan? It is a very straightforward thing. It is a private health care provider providing coverages of A and B, hospital, doctor, as well as the potential to add drug coverage into one plan that delivers all the same rights, privileges, and benefits as Original Medicare, but from a commercial insurance carrier, not Original Medicare. Although you're still in the Original Medicare system, now your cover is provided by commercial insurance. Very similar to major medical when you were under 65 and working or had an employer-based plan. So all that a Part C or Medicare Advantage plan is really just commercial insurance in the Medicare market. And it combines everything together into one plan for you. Now, in Part C, there are a variety of plans. But the most important thing to understand about how Medicare Advantage plans work is that there are two types of Medicare Advantage plans. The first is coordinated care. That sounds good, right? Coordinated care. It sounds like it's going to be delivered to you on a regular, routine, organized fashion. But coordinated care is really managed care. And managed care means that they're managing your health care through networks and affiliations with doctors and facilities that contract with the commercial insurance cover to deliver the healthcare services for you. That's the first type, managed health care. The second type, which we're going to discuss today too, just came out in 2011 in New York State, is called consumer-directed health care. It's a totally different type of animal. We're going to address that. But in the managed health care environment, there are several types. I'm going to point out a few that are real important. PPOs. PPOs are very common, very popular in this area. Why? Because a PPO is a preferred provider organization that says, listen, if you use our doctors and our hospitals, everything will be on a co-payment basis. You see your doctor, it costs you $20. You go to a laboratory, it costs you $100. Everything's co-payments. But PPOs, I'm going to say, promote the value of, hey, you don't necessarily have to stay in the network. You can go out and see any doctor you want. You just pay more. Well, if that's the case, then why have the network at all, right? So when you see the PPO and you're told, hey, listen, it's an in and out of network basis, that's true, but anytime you hear managed care or networks, the purpose of the network is to control costs through negotiating lower fees and services with physicians and providers through a network affiliation. If you leave the network, you just pay a lot more. The second type is an HMO, a health maintenance organization. An HMO is a controlled environment. You cannot leave it. So if you choose an HMO type format Medicare Advantage plan, you have to use the doctors and hospitals in that system. Only can you leave that system if you have a bona fide emergency. So the concept of the HMO is a controlled or managed care environment that delivers health care only within their system. The third type was popular when Medicare Advantage came out. It was called private fee-for-service. Private fee-for-service plans advocated, hey, listen, you can use any doctor, any hospital, anywhere in the country that you want to go to. This is the important phrase. As long as that doctor or hospital is willing to accept the, quote, terms and conditions for payment. What does that mean? That means that if you wanted to see Dr. Frankenstein, he had to say, I accept lower payments and lower compensation for my services below the Medicare rate, and that's the terms and conditions. If he didn't want to accept that, you couldn't see him. So private fee-for-service plans, although they still exist, have kind of gone by the wayside because they didn't deliver what they were sort of promising, which is any doctor, any hospital, anywhere, at any time. This type The MSA is the fourth type, and this is a new type of plan that just came out in 2011, wasn't available until 2012, and now is only available in New York State. The MSA, or the Medicare Advantage Medical Savings Account, is a consumer-directed health plan. It's the second type of plan that was allowed for in the law in '97, but hasn't existed until now. The way an MSA works is very simple. The federal government deposits, and I'll show you how this works, deposits money in an account for you, and you spend it how you see fit on any doctor, any hospital, anywhere in the country, as long as he's a Medicare-approved provider. All right, so that's a very different type of plan. The things that most people buy Medicare Advantage plans for is the things that are not covered generally by Medicare, which is transportation, vision, dental, hearing, all those types of services over and above original Medicare that are not normally covered. Okay, how does Part C work in a nutshell? It's a private insurance contract with a Medicare to provide all the same benefits as original Medicare for a monthly payment called the regional benchmark rate. What does that mean? It means essentially when you join the Medicare Advantage plan, Medicare simply pays a premium for you to that commercial carrier and they provide all your services instead of Medicare bearing the risk. So if you're an original Medicare and you had $1 million claim, who pays it? Medicare does. But if you're in a Medicare Advantage plan and you have $1 million claim, who pays it? The insurance carrier does. Medicare is only responsible to pay a premium for you, which they define as the regional benchmark rate. How do Medicare Advantage plans incentivize you or entice you to join an MA plan? They give you lower premiums, than a supplemental. They give you additional things such as over-the-counter medication, transportation, vision, and hearing benefits over original Medicare that is not normally covered. So Medicare essentially buys a policy and insures you just like you do with home and auto insurance. You transfer the risk for a premium. That's what Medicare is doing in the Part C or Medicare Advantage environment. And this is what they get paid. Essentially, if a plan is considered a 3.5-star plan, they get about $879 a month to insure you and deliver all the same services of original Medicare and take on the risk. It's just like you do with your home and auto, same sort of thing. So, let's go over here. I'm going to address Part D a little bit real quickly, and that's how most people feel about Part D. It is confusing, right? I'm sorry?
The prescription part.
The Part D prescription. It is the simplest program, but it's the most confusing. Why?
Yeah.
Because what happens is there is a standard Medicare plan initiated under law through the federal government. But what happens is insurance companies come in and they put a faceplate on it that makes it look more enticing. But I'm going to show you what the federal program actually looks like. That's where it is, right here. This is how the federal program is actually designed. For 2014, not 2013, you have a calendar year deductible of $310 before your Part D kicks in. Some plans tell you, hey, I don't have a deductible. That's because they put a face on it. They've masked it in some way. Because as long as the plan can deliver health benefits through a Part D to you that is considered, here's the phrase, actuarially equivalent, meaning it's the same, they can put whatever face they have on it. So there's three parts to a drug plan. There's a deductible, and then you pay 25%, and the plan pays 75% until you reach $2,850 in total drug coverage. Thank you. After that, you go into what's called the infamous donut hole, right? The donut hole is where you start to pay. What's going to happen is you're going to pay until the total drug coverage equals $6,455 in the calendar year, and you re-enter into the insurance at catastrophic levels, and you pay 15%, and the plan pays 85%. But what happens is a lot of plans say, hey, if you're in this initial coverage limit, you pay $5 for a generic, $30 for a brand name. You've all seen this, right? So that's just because the plan is putting a faceplate on it. This is how the actual plan works. This is the most important thing to know about your drug plan. It doesn't matter what the carrier is. They're all regulated. What's important is that your drugs are in the formulary. So the easiest way to find a drug plan is you simply go to Medicare.gov. There's a plan finder. You type your drugs into it, and it'll tell you every single plan that has your drugs in it. Because if your drug is not in your drug plan, you're going to have to pay out of pocket. So even though it might have a $20 premium, if you're paying $100 for a drug that's not covered, what are you actually paying? $120, right? So Just make sure that your drug plan has your drugs covered in it, and that's the plan for you. They're all going to be the same. There are 3 types: basic, enhanced, and expanded. Most people fall into the expanded form, which is a comprehensive form that covers generally the top 300 brand name drugs. If you're a heavy drug user, you're going to want to be in an enhanced plan. That'll be about $100 a month.
What is that website again?
Medicare.gov, and you look for a health plan finder, and it'll ask you, what's the drugs you're taking? You just plug them all in there, and that will tell you all the plans in your area based on your zip code that cover your drugs. That's the plan you want to be in. Because if your drugs aren't covered, the plan is useless to you. Okay. Here's what's going to happen, because everybody is, consumers drive the market. Don't kid yourself about it. You have a tremendous impact. And because when the drug plans came out, they were saying, what is this donut hole thing? What coverage? What they did is they enacted a law, and then you'll see, up until 2020, every year the amount you're paying for your drugs in the donut hole is going to continually go down until by 2020 you will only pay 25% for a prescription drug in the donut hole, which is what? It's the equivalent to your initial drug limit. So essentially there will be no donut hole as of 2020. All right. If you make more than these income levels, you're going to pay a little bit more for your drug plan. That's all outlined there for you. And you can always get drug assistance through pharmacy assistance programs direct with drug manufacturers. You can get extra help from the state pharmacy assistance program. There's lots of drugs programs that you can get involved with over and above your Part D if you qualify. All right, so now what we're going to do is, that doesn't look right? It's upside down. That's what Medicare is. It's confusing if you don't know what you're doing. So he's confused. So what we're going to do is now we're going to get into the meat of it. We're going to address how you insure the risks. But here's what's important here. When you think about Medicare and your risk from original Medicare, you have to think in terms of your true out-of-pocket cost. Even though a plan might have a 0 premium, if you have to copay your way to $5,000, that's your cost. $5,000 is your risk, even though you have a 0 premium. So we think in terms of premium and true cost as the key component in making a decision about how you're going to insure yourself in addition to original Medicare. So you got to think about the premium. That's the first thing. The second thing you want to think about is, what are your copays and deductibles in relation to the premium of the plan? That's an additional cost that you'll bear. And then you'll end up at your true out-of-pocket cost. And that's the bottom line for everybody. It doesn't matter if you're paying a 0 premium, because if you're copaying your way from here to Kingdom Come, and you have to spend $8,500 and you have a major illness, that's what you're going to have to come up with. It's your true out-of-pocket cost, not just your premium. All right. So there's 3 terms you need to know as we go through this segment. First, premium. Premium, by definition, is a known loss. You will pay it regardless of your utilization. All right? Premium, by definition, is a known loss. Second is a copayment. That's a fixed dollar that you pay for a service or benefit. It's not a percentage, it's a fixed dollar. And the third thing is deductible. That's how much risk you retain before the plan kicks in and covers you. So those are the 3 key components when you're looking at a plan. What's my deductible? What is my copayments? And what's my premium? And you combine those all together and you end up at your true out-of-pocket cost. So we're going to look at the 4 segments of Medicare insurance and how they work in relation to your original Medicare. The first type is considered a Medicare supplement. This has traditionally been a form that's been around since 1965. But I'm a mathematician by trade, so I break it down all mathematically. So when we look at Medicare supplementals, what's the benefit of a Medicare supplemental? Well, the first and most important thing is that you are in original Medicare. You never leave that system. Medicare is primary for your insurance, and the supplement is secondary and wraps around it and pays all the co-payments and deductibles that Medicare does not pay, such as the hospital Part A entrance deductible of $1,184. So, the second thing that's important about supplements is you can use any doctor, any hospital, anywhere in the country, as long as he is a Medicare-approved provider. Keep those phrases in mind. A Medicare-approved provider anywhere in the country. So, supplements, original Medicare, any doctor you want to go to. Here's how it breaks down. I chose the lowest cost premium in the state, which is $256 a month. That means if you buy the supplemental insurance route, you say original Medicare and a secondary, you for sure, it's absolutely guaranteed, you will spend at least $3,072 in premium. You'll have to add a Part D, which is about another $514 in premium on average. And just to make things fair, I put the deductible in there at $310 for the Part D, and I added dental and vision, which is an optional coverage, but I'm going to show you a par. In other words, everything's going to be the same. We had dental and vision coverage. So if you say, I want to have original Medicare and wrap it with a supplement and these secondary benefits, your annual cost will total, right there at the bottom, $4,136, or about $344 a month, true out-of-pocket cost. But you can see any doctor, any hospital, anywhere in the country you want to go to. That's the benefit of a supplement, because you're in original Medicare. These are the standard plans. It doesn't matter what carrier you go to, all plans are identical. There is no plan difference from carrier A to carrier B. Oh, right, we gotta go back here. Previous. So, I don't want to say there's no point in shopping around, but if you choose, say, for example, the most popular plan, which is a Plan F, if you go to 3 different carriers saying, what's the benefits of a Plan F? It's all the same. It's just a price point. It's a commoditized product that you can choose from any carrier, but you want to make sure that carrier is stable in the market, not entering this year trying to leave the next, all right? So you want to choose a big carrier. Plan F is the most popular plan. Why? It covers everything at 100% on Part A and Part B. You have no out-of-pocket costs other than your premium. All right? But there are other plans that are offered, such as a Plan N, that try to mimic copay plans. You can choose those if you like, but if you really want complete 100% coverage all the time, Plan F is the plan to choose. Okay, here's the first type of Medicare Advantage plan, and here's the important phrase at the bottom here. This is a managed care plan, which means it has a network attached to it. I'm not going to talk about any specific companies in this forum, but I chose the most popular company in the area, and their premium for 2014 is $50, up from $38, up from $0 the year previous to that. So where's the trend going, right? It's going up. Their premium is $600. They include Part D, which is your drug coverage. Why do they include it? Because managed care plans are mandated to be what's called an MAPD plan, Medicare Advantage prescription drug. They have to include your prescription drug. So if you choose a managed care, Medicare Advantage, PPO plan, and your drug is not on the formulary, let's say you're taking, I don't know, Astrovastin as an example, and it's costs $100 a month for that prescription, and it's not in their formulary, what is your true out-of-pocket cost going to be? It's going to be $100 more than $50, right? So that's why when you choose an MAPD plan, a PPO as an example, and it includes your drug plan, if your drugs are not in that formulary of that plan, you're going to have additional costs that you have to account for. I added dental and vision, and here's the important part. Because it's a PPO, they tell you, we're a network plan, but you can go out if you want and choose any doctor you want to use. So of course, because insurance is all about the maximum risk, I chose the out-of-pocket maximum for out-of-network choices, because that's why a lot of people choose PPOs. For 2014, this plan will have an $8,500 out-of-pocket maximum. So if you had a catastrophic claim of $500,000, a heart attack, whatever, you have the potential annual cost of premium and out-of-pocket co-payments of $9,460 or $788 a month. That's significantly more than just buying a supplement, which is insurance, but you'll pay no loss for the insurance. Here, it's a calculated risk. You may not get sick at all, you see the doctor the entire year, and therefore you'll only spend $600, right? That's the risk you take in this type of Medicare Advantage plan. Low premium, but high potential risk of $8,500 out of the network. All right?
It doesn't include the dental and vision.
Beg pardon?
It doesn't include the dental.
There's an option for it. They
Yeah,
have.
but it's extra money, yeah.
Yeah, I included it in there just to kind of give you a par with the supplement, which I included dental and vision with as well. Okay, here's the next type, which we discussed. This is a Medicare Advantage HMO. What do we know about HMOs? It's a closed loop. You can't leave the HMO network unless it's considered a bona fide emergency. life-threatening if not treated within 24 hours. So, what's the advantage of an HMO over a PPO? Well, it actually has a higher premium, up from $44 from last year to $84, but the out-of-pocket is $4,900, half of the PPO if you go in the system. So the advantage of an HMO is that it has a lower out-of-pocket, but it's much more restrictive because it's a managed care solution that you can only use doctors who are part of that system. So for example, if you want to see Dr. Frankenstein at, I don't know, ABC Hospital, right, and he doesn't participate in this plan, you can't see him. You have to use the plan doctors that are given to you. So because you have a lower out-of-pocket, but you have more restrictions, managed care in the PPO and HMO environment basically have that restriction. Okay. The next type is a medical savings account. This is a new plan. It's never existed before until 2012, and this is really the first year you're going to see it. A Medicare Advantage medical savings account is the second type of Medicare Advantage plan that was enabled in the legislation in 1997 under the Balanced Budget Act. But it was not until now that it could be put into practice because instead of just being a managed care plan that only Medicare has to approve, this plan is approved by 2 federal agencies. I'm going to ask, but anybody want to venture to guess who has to approve this along with Medicare? There's money involved. Let me give you a hint. The Internal Revenue Service, that's right. This plan here has 2 pieces to it that had to be approved by the Internal Revenue Service and Medicare simultaneously to be put into effect. The way a Medicare Advantage medical savings account works is essentially like this. CMS or Medicare sets up a checking account for you, and every 1st of January at 1 minute after midnight, a deposit of $2,500 is made in your name in the checking account that is given to you to spend on any medical care you want throughout the entire calendar year. So January 1, right after Christmas, you get another bonus program. They deposit $2,500 tax-free into that account for you to use. You have to buy a Part D plan. It costs $514, and they added all this other stuff in. But after you spend that $2,500 in the calendar year, where you decide what doctor, what hospital, and where, anywhere in the country to go to, you're only responsible for another $1,750 after that. And once you have spent $1,750 and you have spent the $2,500 that was given to you first, the plan picks up and pays 100% of your health care from then on out for the remainder of the year at 100%. So a Medicare Advantage medical savings account has 2 pieces. It has a savings account that's given to you to spend on your health care, and it has a deductible of $1,750 that you have to spend, and after you have those 2 combined amounts spent, the plan covers you at 100% from then on out. If you don't spend the $2,500, you get to keep it, and then January of the next year they give you another $2,500. Thank you. So, here's an example. I'm going to give you an example of the first Medicare savings account beneficiary in New York State. She enrolled in the plan in 2011. She got $2,500, spent only $700 of it. She had $1,800 left coming into 2012. She had another deposit of $2,500. She started out that year with $4,300 coming into 2012. And I can tell you right now, she's got about $4,200 left in that account. So this coming January, she'll get another $2,500. She'll have over $6,500 roughly in her account, and her risk is $1,750. She's a winner, and she never pays any premium. This is a zero premium plan. Why is it a zero premium plan, unlike other types of Medicare Advantage plans? Because the law says it so. Only a Medicare savings account has a zero premium plan required, not mandated by decision. So when you have an MSA, or a Medicare savings account, you pay no premiums. You have to buy a drug plan because the drug plan is not included with the MA side by law. It's the way it's designed. Why is that important to you? Because you want to go to Medicare.gov and search your drug plan, and you might find a drug plan that covers all, in fact you will, you'll find a drug plan that covers all your drugs, but it may not be with this carrier. So let's say you buy your drugs from carrier A, and you buy your MSA from carrier B. Now you have complete coverage, and your true out-of-pocket cost is not including things that are not uncovered. You follow that? It's a very important aspect. So MSAs are unique, and they're only available as of this year. You've probably never seen those before. So the four major types of Medicare Advantage plans, here's an illustration of it. How's it working? You get a deposit of $2,500 into your account. You pay it until you meet your deductible, and that's $1,750, and then the plan covers you at 100% thereafter. Okay. So, coverage solutions in 2014 are going to be the same as they were in 2013 and every year before. If you have Part A and B, and you want to eliminate the risks of deductibles and coinsurance, you have two choices. It's pretty simple. You choose a supplement, which is secondary to original Medicare, or you choose a Part C, a Medicare Advantage plan, and you have to kind of decipher, do you want to be in managed health care, or do you want to be in consumer-directed health care? If you have Part B, same issue, deductibles and coinsurance, and you have the same option, supplement or Part C, one of the two. And for drug coverage, you always have to get a Part D. The only question is, if you're in a managed health care plan, they will give you the Part D, and if you're in a Medicare savings account, you get to choose any Part D that's available in the market along with your MSA. Those are really the only solutions you have relative to going what we call in the business naked, just having Medicare only and no other insurance. Okay, issues to address in the risk solution is the network of physicians and services. If you have a specific doctor you want to use and you're choosing a managed health care plan and he's not in it, can you use him? No. Right, unless it's a PPO and you opt out. If you're in a consumer-directed health plan, it's any doctor, any hospital, anywhere in the country at any time. Referral requirements, again, managed health care has those. Areas of service, if you live here 6 months and you live in Florida 6 months, if you're in a managed health care plan, you have to possibly change your plan when you're going back and forth. If you're in supplementation, you can keep your plan, it works anywhere in the country. And if you're in an MSA, a consumer-directed health plan, you can use it anywhere in the country. You never have to change or be subject to those changes. You want to look at your premiums, your co-pays, and here's the most important one. Carrier stability. As I showed you before, carriers in the Medicare Advantage market come in, figure out they can't make money because of the way the plan's designed, and get out. And then you're kind of back to square one, choosing a health plan. Here's another analysis that I do all the time. I analyzed every possible plan from the MSA, the HMO, the supplemental, and the PPO. And you can see, in the end, PPOs could potentially be the most risky financially for you because they have high out-of-pocket maximums. Even though the premium could be low, the co-insurance, the deductibles, and the co-payments that you have to make can add up to significant numbers, about $788 a month on the potential high end of the risk. Supplements, fix your cost. You have a premium. There's no additional cost to you. You just pay your premium and you're done. But they could be upwards of $344 a month. And then the MSA has the lowest out-of-pocket cost at $218 because it's limited to $1,750 in the calendar year. So the MSA has the lowest out-of-pocket cost and a zero premium. So that's that. Here's another analysis that I always do. How many doctors can you see? Well, if you chose a PPO, there's about 4,172 doctors available in most PPOs in this region here. So you have a limited world of about 4,100 doctors in the New York area who operate in the PPO environment. If you had a supplement, you can literally see all doctors in the United States, 789,000 of them. So, I mean, a supplement offers the widest variety of doctors. HMOs, there's about 4,172 HMO doctors in this area. And again, MSAs, because there's no network affiliation, it's any doctor, any hospital, anywhere. Again, every virtually doctor in the United States is available to you, 789,000 of them. Let's skip that. So, I know we're trying to get through this real quickly. If you have any questions, there's a questionnaire sheet in the back of the book that you can write your questions in. And here's the most important part. On the front sheet of that book, let me just put this over here. There's something called, the second page, this is required by federal law. I can't address any question, hopefully you have questions, hopefully I answer the questions, but if you have questions, I technically can't answer any question unless you sign the scope of appointment. You see it in the back of the book there? Right next to the questionnaire sheet. So if you have a question, the first thing you have to do is sign the scope of appointment, and that allows me to talk to you about your question. The
You
second,
said there was no cap on the original Medicare. Well, why doesn't the government put a cap so the person after $10,000 could stop?
they effectively did. By creating a Medicare Advantage plan, those plans have out-of-pocket limits. As an example, in the PPO, it's $8,500 out of the network. So that is your cap. But the original Medicare program has no cap on the 20%. It's unlimited. Right. So, if you have a question about anything I addressed, I know this is very general, and you probably have specific questions to you, possibly. Write your question down. You sign the scope, I can sit with you and talk to you. But if you don't sign the scope, I can't do that. It's prohibited by law. All right? Also, I put some sheets on your table. If you want to attend another event, like you didn't get everything here, we have other events. I put those on your sheet, or if you know somebody. And if you have, what else we got on the table there? I guess that's it. So any questions, just please sign the scope. My assistant Kevin is here. My assistant Dylan is here. They'll be able to help you out. They're over here. And just write your stuff down. Yeah.
Very general question. Is there any income limitations to any of these plans?
Are you working with him? Or can I ask you a question?
It applies to everybody. There is no income limitations unless you're in Medicaid, which is considered dual eligible. Yes, sir.
I currently have.
Let's give it to your beneficiary. Everybody get the question? No. If you get a check in the MSA deposit and you pass away, the money goes to your named beneficiary. It transfers by operation of law to your named beneficiary. Sign your scope of appointment, give us your name and number, and Kevin, myself, my assistant Dylan will call you and send it to you. Yes, sir. The MSA? No, there's no insurance companies do it. Insurance companies do it locally here, but you can get it through our firm. We'll send you all the information on the plan. You can get it. It's through a carrier in Western New York.
Maybe I'll see you for being on.
Yes, sir.
Everybody's giving me different stories.
Are you curious as to know why they told you one thing and doctors? What happened is, this is interesting, because it is a network, because it is managed care, physicians how to get into their rate is being their reimbursement rate being reduced. They get courted back by them throughout the year. They get courted back and say, oh, well, we'll give you a better rate. And they put the skills to make it, they say, I'm doing it, so they don't renew the contract. Well, another way anyway, so I have an appointment Thursday. So with a rep from United Health that wants to talk about another medical science.
Very good.
Any other questions?
I don't know, it's a blessed mother.
Kevin,
Yeah, sure.
this young lady's going to give you some paperwork over here.
I use that to get school shield and then they just put in $378 a month for my wife and myself. I love it. I won't take a plan. It's a sweet plan. This MSA.
So when are you saying you're not happy?
I'm saying, you want to, I'm not going to sign up yet.
Fuck this, you want to see us after?
Not on Thursday, but maybe Friday. Give me a number and I'll call you. Or I'll give you my
I'll call you after Thursday. I'll call you after Thursday.
All right.
Okay. Hi, how are you? Did you fill out the form? Yeah, okay.
Yeah, we do seminar.
Yes, you're talking specifically about the MSA. You want to
want to do this now, could I call another time?
You can call, but we still have to get, even to call and ask questions, we still have to get basketball forms filled out by federal law to answer any questions.
I'll fill it up and everything.
Yeah.
And what do they mean, the vouch what? Vouch number. They should get a vouch number.
Don't worry, that's just to track the seminar.
See, I don't have anything right now, but I don't know what to do.
Are you turning 65?
I am already, but I don't know if I want to change this year, but I might want to change next year.
Fill that out, and we'll set up one, either telephonic or face-to-face. And answer
Can't
all your
mail this in if I...
You want to mail that to me?
Yeah, if I decide I want to do it.
I was saying that you, if you decide, got it. So, you know, put some more in.
Okay, listen up, everybody.
Kevin or Roy?
Okay, if you have to ask George any specific questions, please sign that paper that he said he can't answer anything. It's rules and regulations from the government. Okay? And if we can do that, then you can go up to the nurse's office so you can talk to him privately. It would be nice.
But I'm aware of
When did I speak to you?
Okay, it would be easier if everybody gets their own time.
That's definitely a question for George, because that's his specialty. He's getting swamped. Do you want to fill out the form? Oh, you did? Okay. Are you together? No. You're not, sorry. So put your phone number on there. Do you want to fill out the form? Well, that's very much. Yeah, you don't need to fill a form to find out. I don't want to let go. What's the situation?
Take care of
Ladies and gentlemen, we have to get lunch started, so those of you that have questions, please go up to the reception desk. Please, thank you. And George will answer anything that you like.
I will call you as soon as you like me.
Okay, if you have a question, please go up to the reception desk.
Yes. So do that.
I'll get another.
We'll get you a, I'll get you a phone number. I just have to.
Yeah, there's a whole bunch on the table. We're allowed, I think, the rest of the way. They're doing it this time around. It's bad because we've got to go into lunch, so this is not a good, really question.
Okay, if you have any question and you want to talk to George, he's up near the reception desk, and I have one young man near the wall that's going to give them the paper to sign. They will call you back. They did a very good presentation. So make sure you take all the papers from his telephone number, everyone. Okay, make sure you take the telephone number if you need to call them.
Our assistant will. The young gentleman. Kevin will do it. Kevin will do it.
Watch the wire, please.
Kevin?
be careful as
applied
you
for
walk.
Social
Watch the
Security
fire.
last week. Do you know how long it takes?
Okay, those of you that are staying for
I
lunch,
feel very nervous because I had applied under my spouse, and they said they didn't see the divorce decree, and they had scanned it last year. So I went over there and I brought it, and the woman said she'll take care of it. But I don't know how long it's going to take before I hear from them.
How long?
Have a guess?
I'm sorry. Yeah, I'm gonna give you my phone. I'm sorry. I wrote down your question.
Do you have an idea how long it takes?
everybody who's having lunch, please
Best
be
option is to
seated.
call SSA. You just got
Everybody
Medicare
who's
now.
having
Is that
lunch,
what
there's plenty of seats here. There's enough seats for
And I know it's a long
140
wait
people.
with the prompts and stuff.
Please take a seat.
Did you write this down?
Ladies and gentlemen,
What we can
Your best bet is to call SSA and Social Security Administration.
I think
Wait it out.
Anthony, is anybody hungry today? Okay, and I think Anthony's ready in the kitchen,
wait it out.
so if we can have your undivided attention, I really would
Because I got
appreciate
a
it.
bill now to pay my Medicare. I got a bill.
Thank you.
Peoples,
Well, they said that they'll switch everything.
Peoples, it was a great opportunity
Take
to
it out of the
learn
Social
about
Security
this.
check automatically every month.
Yeah,
But you can't, if you're speaking, you can't hear
You
me.
know, because I'm under morning.
Got it.
Please, if any other people have a question and they're not having lunch, please go up towards the reception desk.
Let's take them
And you will
upstairs,
answer
okay?
your questions at the nurse
But I think it's about
desk.
6
I
years,
really,
right?
thank you.
It could be.
Thank you, Fonda.
Hey, Angie.
Thanks for coming down.
Okay.
Is this what you call successful?
Good morning.
We like that.